Greetings. I am Lori Hendrick, a PhD student at Old Dominion University's School of Public Service. In addition to pursuing my PhD in Public Administration and Policy, I am very involved in dentistry in North Carolina as a dental hygienist, a dental lab owner and technician, and currently serve as the president of the North Carolina Dental Hygienists Association. Recently, I was involved with the state task force advocating for the legislation of dental hygienists to administer local anesthetic and utilize teledentistry in rural areas. I am excited that our legislation has reached crossover this month in the North Carolina General Assembly and is likely to land on the governor's desk for final signatures by September. I am honored today to speak to you on another concern that we face as dental providers, and that is access to dental care in rural American cities. Recently, the U.S. Surgeon General declared an increase in dental decay and other health concerns as a silent epidemic affecting the most vulnerable citizens. This is due in part to a shortage of dental practices in rural areas, combined with an increasing population, which places the citizens residing in these rural areas into high-risk groups. Consequently, there is a need for policymakers to examine collaboration between public, private, and nonprofit stakeholders to reduce disparities among populations. Policymakers can achieve this by positioning oral health as an issue of social justice, health equity, and human rights, thus improving the overall oral health of all citizens. In researching just how widespread the oral health care inequities appear to be across the United States, themes across literature were that citizens in rural communities faced a multitude of challenges in obtaining health care in general. Furthermore, research demonstrated that residents in rural communities have a higher incidence of dental decay, loss of permanent teeth, and other dental sequelae, which negatively affects life. Research determined that our most vulnerable citizens are those from low socioeconomic families, elderly living in community or assisted living facilities, and some members of ethnic minority groups. While lack of access to dental care for all ages remains one of the largest health concerns for Americans, recently the lack of demand has also been evaluated as equally concerning. In 2020, the ADA, the North Carolina Dental Society, and the North Carolina Department of Health and Human Services conducted a study to evaluate the utilization of dental benefits among public programs such as Medicaid. The ADA Health Policy Institute study showed that in many areas of North Carolina, there were an adequate number of enrolled Medicaid providers. However, the beneficiary utilization remained well below average, leaving leaders to conclude that there is more of a demand problem than an access problem in many areas, especially among the adult population. When evaluating point of care among different ethnic groups, this study did not find statistical differences among white citizens and those of communities of color. The largest disparity found was among Latinx communities. How can policymakers address this? Shouldn't we examine the reason for the lack of demand? Is it truly due to barriers in care, such as transportation and even the lack of dental education? The suspicion without research is that many adult Medicaid beneficiaries often have overlying medical conditions that limit their access to care. This may include disabilities that make getting to the conventional dental practice impossible. It could also be due to developmental or mental disorders that again make a trip to a dental office impossible. It is estimated that 47 million Americans, or roughly 20% of the population, resides in rural areas that have been designated as health professional shortage areas by the U.S. Department of Health and Human Services. For those who may be unfamiliar with this designation, it has been established by the Bureau of Health Workforce to identify areas within the population of the U.S. that are considered to be currently experiencing a health shortage. HPSA scores 3 paradigms across healthcare, that being primary care providers, mental health providers, and dental care providers. HPSA is scored as a ratio of the number of healthcare providers relative to the population, with additional consideration given to high-risk populations. Since I am focusing on the aspect of dental care, I want to point out that the population to provider ratio must be at least 5,000 to 1. If the area is determined to have a higher rate of needs, the ratio is adjusted to 4,000 to 1. When an evaluation determines that a higher level of need, the ratio of citizens per dental provider is reduced. Evaluations are performed annually in July. Many professional organizations, such as the American Dental Association and the North Carolina Department of Health and Human Services, however, prefer to use a census tract examination of utilization and provider participation as a truer picture in public health programs than the HPSA to determine where shortage areas actually exist. In 2019, an in-depth study utilizing census tract information, for example, showed that an adequate number of dental providers existed in most counties in North Carolina. However, shortages still exist in access to care. Furthermore, research shows that only 14% of dentists in the United States often practice in rural locations. Across all healthcare paradigms, the socially disadvantaged individuals of low socioeconomic status present poor overall general health. Keeping our focus again on dental, research has shown a reduction in the prevalence of dental diseases, although it continues to remain higher among those populations of low socioeconomic statuses. Research suggests that the people who have the least access to preventative services and dental treatment have greater rates of oral diseases. Therefore, socioeconomic indicators are associated with risk factors for dental diseases. Due to the permanent nature of socioeconomic indicators, studies that evaluate such indicators trend to be observational rather than interventional. Newer research suggests that although a number of epidemiological studies have evaluated associations between dental diseases and socioeconomic indicators, no systematic reviews in the literature exist that offer scientific evidence of such associations. In conclusion, the findings provide evidence that worse socioeconomic indicators, such as a subject's schooling, income, occupation, and the Gini coefficient, are associated with a greater severity of dental diseases. The United States Surgeon General has defined oral diseases as a silent epidemic that affects the most vulnerable citizens. Despite the advances in preventative and restorative methods to address the most common oral diseases, people of all ages continue to experience poor oral health with profound disparities among U.S. populations. This includes those from a low socioeconomic background, such as children, elderly, and even some ethnic minority groups. Although preventative and treatment modalities have improved over the past 50 years, some Americans still do not have access to preventative programs. Many citizens face barriers to care which prevent them from seeking dental care until it progresses into a life-threatening medical emergency. The oral health care program in the United States, as well as globally, is structured independent from overall health care, although there are systemic connections that are documented in the literature. The average child enrolled in Medicaid or state child health programs, such as CHIP or Health Choice, are most likely due to low socioeconomic status, whereas adults are more likely to exhibit an extenuating medical emergency. Even with access to programs such as Medicaid, federally qualified health centers, veteran services, and local dental clinics and public health departments, dental care shortages purportedly still exist. While barriers exist that prevent elders in community living centers from obtaining oral health care, current research is focusing on gaps that exist that disproportionately place poor Black and Brown Americans at high risk for dental emergencies. Disparities in healthcare can translate into missed days at school and missed days at work, which carry ultimate economic implications. Understanding where our inequalities exist position policy advisors with more favorable advantage when addressing these concerns. Let's take a look at the recent data utilizing the NANE survey on oral health care that was analyzed by DataQuest. It demonstrated that Black adults are 68% more likely than white adults to have an unmet dental need. Latino Americans are 52% more likely than white adults to report difficulty doing their job due to poor oral health. Nearly 4 in 10 Black and Latino adults reside in 14 states where Medicaid have cut adult benefits, offering no services or only emergency care services. While citizens lack access to preventative dental care, they are less likely to be able to maintain good oral health. Policymakers can begin addressing equity by promoting dental and oral health education to children at a much earlier age. Dental education is absent from elementary school health education or is relegated to 1 month out of the year, typically March, when Dental Health Month is observed. Most schools rely on dental volunteers from the community to come into the classrooms to briefly discuss brushing techniques and how dental decay develops. While any exposure can help break poor family dental health cycles, this little exposure is not enough to promote optimal health. Across the nation, many community partners often attempt to implement cost-effective interventions which continue to demonstrate inadequacies to alleviate shortages in delivering oral health care. Many studies, Many studies have discovered that community dental knowledge remains low in many rural areas. Therefore, one of the first steps in breaking down barriers and providing equitable access to affordable oral health care services should focus on prevention-oriented services across multi-sectorial collaborations. Community collaborative practice models, such as a nonprofit economic model, represents a sustainable, patient-centered approach to overcoming barriers and providing oral health care. Community nonprofit models build on the conceptual framework of the private dental practice. However, it expands to include proactive and responsive systems as well. Research demonstrates a sustainable nonprofit model can be tailored to deliver oral health care through a collaborative effort with a community partner. This provides equitable access through a multi-sectorial action, providing affordable oral health care services based on education and prevention orientation. States and local communities may begin by shifting the focus from providing oral health care to social justice, health equity, and human rights. Social justice and human rights refer to the fair and proper facilitation that all rights are inherent to all persons. Whereas health equity is the ability for all persons to have the same access to obtain the highest level of care of health available to all people. Policymakers are challenged to eliminate healthcare disparities, which can be achieved by ensuring that structural personal conditions are in place to support obtaining optimal health for all. Policymakers, researchers, and public health practitioners have long sought not only to improve overall population health, but also to reduce or eliminate disparities in health based on geography, race, ethnicity, socioeconomic status, and other social factors. The World Health Organization defines health inequities as systematic differences in the health statuses or the distribution of health resources of different population groups. Whereas health inequalities are the unfair and avoidable differences in people's health across social groups and between different population groups. As defined, inequities arise from social conditions in which a person is born, lives, or works. Unfair health inequities can be addressed or reduced through effective policymaking. Let's briefly look at the overarching aspects of healthcare nonprofit organizations through the theoretical lens of government failure and social equity theory to increase the access to care, improve quality, and raise the overall quality of oral health. Government failure is a situation where government intervention in a market is often to correct a market failure. It results in the inefficient allocation of scarce resources. Since the inception of the Affordable Care Act, many government laws, regulations, guidance, requirements, and policies, both at the federal and state level, have reduced incentives for price and non-price competition, increased barriers to entry, promoted and allowed excessive consolidation, and resulted in healthcare markets that lack the benefits of vigorous competition. Specifically, government has encouraged the third-party payment, created counterproductive barriers to entry, incentivized opaque pricing practices, skewed innovation activity, and placed restrictions on reimbursement policies of government programs, specifically those such as Medicaid. Overall, these practices have resulted in less choice, less competition, and suboptimally functioning markets that deliver higher prices and lower quality. Since government intervention in healthcare, specifically oral healthcare, has increased shortages in providers, nonprofit organizations in many communities and states have stepped up in an attempt to fill the void that now exists in delivering oral health care. Social equity is often referred to as the fourth pillar of public administration. The Standing Panel on Social Equity in Governance of the National Academy of Public Administration defines social equity as the fair, just, and equitable management of all institutions serving the public directly or by contract, and the fair and equitable distribution of public services and implementation of public policy, and the commitment to promote fairness, justice, and equity in the formation of public policy. Therefore, should policymakers seek to prevent and reduce inequality and inequities based on significant social characteristics, thus promoting greater equality in access, procedural fairness, and in the quality of services and outcomes, including oral health. Government failure theory suggests that nonprofits emerge when private markets do not serve communities of interest adequately. Nonprofit organizations foster civic engagement, leadership, drive economic growth, and strengthen communities providing services and goods to fulfill the gaps when market failures exist. Market failures in healthcare occur due to models of access to care that are driven by the type of funding, be it private or public, where access to care is tactically viewed as being a determinant by the cost of care to the patient. Thus, exploring policies and programs that overcome market failure should be evaluated on a broader scale as potential alternatives to delivery of care models. In many communities across the United States, our nonprofit organizations have formed to provide services in community care facilities, hold clinics for veterans, as well as provide screenings and educational materials in elementary and middle schools. Throughout our history, nonprofits have adapted, changed, grown, and altered their missions and goals to continue to serve the emerging needs of our society. Historically, struggles that affect entire populations on a global scale tend to benefit nonprofit formations. An example of this is the institution of nonprofits in the delivery of healthcare, specifically when addressing inequities in oral health care. Apple Tree Dental was a nonprofit conceptualized and founded in 1985 by several dental school classmates. They sought to address the lack of care in the elder population living in community care centers. At the time, in 1985, nonprofit dental practices were almost non-existent. However, the foresight of setting the practice up as a 501c3 nonprofit organization has proven critical to the sustainability of Apple Tree Dental. The mission of Apple Tree Dental is to improve the oral health of all people, including those with special needs who face barriers to care. Employees and volunteers ensure that this mission is achieved by providing education, preventative procedures, and restorative dental services to the vulnerable populations, and also by providing leadership and innovation to transform the oral health care system in Minnesota. From a meager startup in 1985 with one portable dental chair, in over 35 years, Apple Tree Dental has grown to employ over 200 dental practitioners in 8 clinics across the state of Minnesota. Apple Tree Dental also provides on-site mobile dental services for over 130 community oral health centers, schools, nursing facilities, and long-term care facilities, taking dental care into the communities where it's needed. In 2020, pandemic-related restrictions impacted the total amount of care that Apple Tree Dental was able to provide, resulting in fewer patients and fewer visits in what occurred in 2019. In 2020, however, even with those restrictions, Apple Tree Dental still provided over 64,356 dental visits and screenings for more than 29,158 patients. Analyzing the data from Apple Tree Dental for over 35 years, Apple Tree Dental is witnessing a growth in the under 21 age group. Over the years, as witnessed by this slide and the following slide, we can conclude that this nonprofit dental practice is trending to fulfill more gaps in younger disadvantaged populations across the state of Minnesota. Dental care services that have been provided by Apple Tree Dental in 2019 reached an all-time high of $31 million. Since 1985, Apple Tree Dental has provided over $335 million in dental care. This definitely represents a sustainable system of care for people of all ages. Patients in their clinic are not excluded due to insurance status, age, or abilities. Due to the low levels of reimbursement from Medicaid and the high levels of uncompensated care in uninsured populations, Apple Tree Dental has developed multiple funding systems to support a sustainable business model. Revenue for Apple Tree Dental is earned by providing dental services to both insured and private pay patients. It is further supplemented with federal, state, and local foundation grants, corporate support, and individual gifts. Dr. Helgeson, CEO of Apple Tree Dental, and his team wanted to implement a plan that would help to address the lack of access to dental care for residents of nursing homes and assisted living facilities. However, they quickly realized that the barriers to oral health care and overall health consequences of dental diseases far reached those living in those assisted living facilities. Overall health consequences of dental diseases were not widely recognized in 1985. Likewise, the necessity to integrate dental care into unconventional dental settings had not become part of health policy efforts. Therefore, Helgeson and his team recognized that the high cost associated with untreated dental sequelae and the negative effects on a person's overall health provided a strong financial motivation to overcome barriers and reduce disparities in access to care. Apple Tree Dental has formed successful collaborations with the Minnesota Department of Health and Human Services, the Minnesota Board of Dentistry, state legislators, state and regional oral health coalitions, dental professionals associations, which include the American Dental Association, Special Care Dentistry, the Minnesota Dental and Dental Hygiene Associations, many patient advocacy groups, and many local leaders. Funding has been implemented and provided by grants and has funded projects such as teledentistry, silver diamine fluoride, and interdisciplinary educational experiences. Apple Tree has a board of directors who are their leaders and paid lobbyists and help keep a watchful eye on oral health policy and ways to influence public program reimbursement rates. The board of directors have also increased the reach and effectiveness of the dental team through workforce expansion. For example, by advocating for the establishment of the collaborative practice for dental hygienists in Minnesota, they helped advance the discussion of mid-level providers and advanced dental therapists. Advocating for the patient, they have advocated for the reinstatement of benefits for specific services that had been cut from adult beneficiaries of Medicaid. Through a well-defined mission, all parties understand the shared values that support both patients and providers. Mission and values are key to developing and maintaining strategic partnerships with both public and private entities. Team development at Apple Tree includes all aspects of a business, such as human resources, financing, IT, marketing, and communications. Effective public policy involves having representation at the state capitol to help influence policy making. By investing in lobbyists, the dental care providers are able to focus on dental care delivery. By diversifying sources of grant and gift income, don't always depend on few funders. Dr. Helgeson states, it is best to underpromise and overproduce on grants. Apple Tree utilizes a nonprofit staff where the dental professionals are paid employees, which allows them to provide the same standard of care regardless of the payer. Being able to recruit and maintain mission-focused leadership and team members allows Apple Tree to remain focused on caring for the community in need. Organizations that depend on volunteer dental providers often find that in a time of need, they are unable to secure providers to care for patients who show up in need of care. While there have been 5 successful replication programs in other states as a result of the successful model provided to Apple Tree, Dr. Helgeson warns that a cookie-cutter replication is not possible. In order for a program to be successful, it must be tailored to the local and specific needs of the community. Available resources and state-specific licensure or dental board regulations must be considered. One must be willing to analyze highly specific local data and maintain ongoing program evaluations in an effort to be successful. Currently, the population that utilizes Appletree Dental's sustainable practice model has grown from senior and elders in long-term care facilities to include those low-income children and families who reside in both urban and rural communities. Appletree has demonstrated a sustainable way to provide care that is met to citizens in their communities, involving community leaders and professionals who know the community best. Finally, reaching out to the community across the state and even nationally for partners with whom to collaborate to address disparities in access to care. This model has shown that it can be successful for over 35 years and can be adapted to serve specific communities. Historically, dental care is provided in private practice settings with low reimbursement rates from public insurance programs and low-income patients, making it difficult for the traditional private practice to survive if a significant number of patients are on public assistance. Typically, in most states, Medicaid does not provide dental coverage for adults, and when services are covered, the private practices receive reimbursement rates that are less than half of the usual and customary rates for that area. This creates gaps in the market as private dental practices cannot operate under these financial constraints. Appletree's model provides a legitimate patient-centered approach to provide dental services to those communities in need. Operational capacity is achieved by building innovative practices which allow services to be provided in shared spaces where staff utilizes the community's resources. Appletree's nonprofit status allows the organization to keep costs low as additional financial concerns are addressed through grants and fundraising. Networking occurs through a multidisciplinary collaboration that addresses oral health care reform to improve the experience of care, improve the health of populations, and to reduce the per capita cost of health care. The community collaborative practice developed by Appletree is a sustainable, patient-centered program that focuses on overcoming barriers to care, which can occur across the entire lifespan of citizens. The rising costs and significant healthcare consequences from untreated oral health sequelae have recently caught the attention of many policymakers. This has resulted in a call for sustainable oral health care delivery models that can meet the needs of the underserved. Appletree Dental demonstrates an entrepreneurial approach to enriching the lives of others through advocacy and a business model that does not and is not established profit as a goal. In closing, I would like to leave you with a quote from Jocelyn Elders. "Health is more than absence of disease. It is about economics, environment, empowerment, and community. The health and well-being of the people is critically dependent upon the health system that serves them. It must provide the best possible health with the least disparities and respond equally to everyone." Thank you for your time.